My name is Zaim Khan. Today I'm going to be discussing the etiologies of peripheral foot drop. This is a common way that patients will present to the neurology service, whether you're in the clinic or the ED, so it's important to get familiar with the etiologies of what could cause this. Um, I'm going to be talking about how to tell these apart using just your neuro exam. So some of the d definitive diagnoses, you could use imaging, you could use conduction studies, but a lot of these really you really can tell apart using just your standard neuro exam and maybe a couple of additional maneuvers. First one I'm going to talk about is the L4 radiculopathy. Um, this one is actually a little bit unique because it affects knee extension, which none of the other etiologies I'm going to be discussing today affect that. It also has a decrease in the patellar reflex. It's the only one that has certainly a patellar reflex decrease, one of the only other ones that affects reflexes in general. So if you're getting knee extension plus a knee reflex decrease, L4 radiculopathy should be very high in your differential. Something else that's going to help you tell this apart is by looking at the regions of sensory loss. It affects the medial leg and the medial ankle. Notably, it doesn't actually affect the dorsum of the foot. Has a little bit region in the back, but this is going to be easy for you to tell apart from L5 as well. And so moving right into L5 radiculopathy, um, this radiculopathy will affect toe extension. And one of the ways you can tell this apart really is by looking at the map of the sensory deficit. Uh, it's a, really localized to the lateral part of the leg, and then notably it affects the dorsum of the foot. So these actually should be quite distinct even on a very coarse neuro exam. Because both of these radiculopathies emerge from the spine, something you might consider doing is a straight leg test, which stretches out these roots and as they exit the spine and can really elicit the pain that you might see in like a sciatica if someone has back pain. That can really help you narrow down to this diagnosis. The other thing is that L4 affects hip adduction. So you might want to consider doing a hip adduction test to test the strength of that, and if your L4 is on your differential. Both of these can be hurt, usually in like a disc herniation or something like that. It would be associated with back pain. So that's something that you want to keep in mind if you're getting a history and correlating that with your exam. A little bit farther down, if we're following these nerves, is the common fibular nerve palsy. Um, this can affect your toe extension. It'll affect your eversion, which is something that is unique to the common fibular nerve palsy out of the ones that we're discussing today. Um, you won't have back pain because the common fibular nerve is a little bit farther down. It'll be on your leg, and it's commonly compressed if you have like a fibular head fracture or something like that. It's superficial, so it can be hurt due to trauma. And one thing you want to keep in mind, as with all of these, is keeping in mind these sensory changes. So the common fibular nerve is, as the name suggests, the combination of the superficial and deep fibular nerves. So it's actually going to affect all of these regions here. You might notice that it extends to the dorsum of the foot, but then covers this like lateral line here, which is quite similar to the way L5 might present. So you might have a little bit of trouble telling these apart just from the sensory exam. What's really going to help you tell this apart is this kind of history of back pain, getting history of how this injury actually occurred, and then doing an eversion, a motor strength test is going to be crucial to tell these two apart. The next nerve is the deep peroneal nerve palsy. Um, it's not going to have an effect on eversion, so that's the difference here. But the sensory exam is going to be extremely different. So as you can see here, it really affects this web between the first and second digit on the lower extremity. And so that's going to be very distinct. And this, if you see this pattern of sensory loss, deep fibular nerve damage should be extremely high in your differential, and it's going to help you tell these apart. This is commonly damaged if you, for example, have like a very tight foot shoe. It can be compressed as it enters the anterior ankle. The last one we're going to discuss today is the tibialis anterior injury. This one is actually quite straightforward. It is isolated dorsiflexion, not affecting extension or eversion or anything like that. It doesn't have any reflex changes, obviously, because it's a muscle. And then for the same reason, no sensory loss. It's located on the shin, so you should expect a history of sort of some kind of shin trauma or maybe overuse. But I think this one should be relatively simple to piece apart. Anyways, I hope this was helpful, and I hope you can use this to use your exam to come up with a solid differential diagnosis for the next time you see foot drop presented to you. Okay, thank you.